All right. Good afternoon, good morning, everyone. I am super happy to welcome everyone here. I'm Nick Dobbins. I'm an assistant professor here in biomedical informatics and data science at Johns Hopkins, and I'm very happy and grateful to welcome my friend and collaborator Dr. Kevin Lybarger. Kevin is a tenure track assistant professor in the Department of Information Sciences and Technology at George Mason University. Kevin has a focus on information extraction from clinical text, annotation schema design, creation of high quality data, high quality research data sets, and development of task specific novel NLP architectures. And I'm sure we'll get a chance to kind of learn more and unpack all of that. Kevin completed his PhD in electrical and computer engineering from the University of Washington. He had a master's in electrical and computer engineering from University of Colorado Boulder, and a bachelor's in that as well from Seattle University. And with that, thanks everyone again for joining, and I'll hand it off to Dr. Lybarger.
Thank you, everyone, for coming to this talk. To my wife's chagrin, I have no disclosures, unfortunately. So this talk is going to focus on social determinants of health within the EHR. And so the objectives are to be able to better understand how social determinants of health are represented in the EHR and the role that natural language processing, or NLP, can play in utilizing that text information. So the title of my talk is Extracting Social Determinants of Health, Annotation, Extraction, Information Gain, and Ethical Considerations. It sort of spans a fairly wide gamut, and this is a work that was performed in conjunction with the University of Washington and George Mason University. So Nick or Dr. Dobbins indicated you had a bit of a primer about SDOH. So social determinants of health, or SDOH, are the conditions in which people work and live that impact their health. And this can include a wide range of social, behavioral, and environmental factors. And knowledge of social determinants of health can inform patient care. Now, these SDOH are documented in the electronic health record, both through structured data and through narrative text clinical notes. And in many cases, these clinical notes contain a more nuanced and detailed representation of the SDOH. In order to use the SDOH information that's captured in this narrative text in a secondary use application, we need a way to take this unstructured text representation and then map it to or transform it into some structured representation. And once we have this structured representation of the SDOH, we can then incorporate these data into a wide range of secondary use applications like real-time clinical decision support tools, large-scale retrospective studies, and other applications. This slide shows sort of an overview of sort of in general, like the goal of what I would just call clinical information extraction, where we have this electronic health record data that contains structured data and unstructured clinical text. In this case, we're focusing on clinical notes. And in information extraction, we want to develop machine learning models that can take this unstructured text, map it to some structured representation that then we can recombine with the available structured data to create a more comprehensive or complete representation of a patient or a person, to then be able to improve their health outcomes, inform their care, do population health work, all kinds of downstream applications. So in this talk, I have sort of a sequence of research projects that we've performed spanning from my PhD until work that was just recently submitted for review. So first, I want to provide an overview of a SDOH corpus that we annotated as part of my doctoral work, SHAC. Then I want to present some high-level description of state-of-the-art information extraction models that have explored this data set in the recent N2C2 challenge. Then I'm going to present one, I guess I would call like a baseline information extraction model, MSPERT, that Dr. Dobbins and I have used in our research. Then I'm going to present a case study where we explore the prevalence of SDOH within the EHR. Then I want to move on to work that is incorporating large language models and explore different prompting strategies for extracting SDOH. Then I want to talk about different strategies for normalizing SDOH information to concepts, which also will continue to leverage large language models. And then finally, I want to conclude the talk with some ethical considerations based on some work that we've done trying to understand patient and clinician acceptability of using AI to essentially mine clinical records. Okay, so first, this annotated SDOH corpus. So as part of my doctoral work, we created the Social History Annotated Corpus, or SHAC. And this corpus includes clinical notes from MIMIC-3 and the University of Washington. We extracted social history sections from these notes, and we annotated them using an event-based annotation scheme that I'll show on the subsequent slide. In this data set, we have separate partitions for train, development, and test for each of these two sources, MIMIC-3 and UW. And one point I would throw out there is that a majority of the training set of this SHAC was selected using active learning, which I'm not going to highlight here, but I just wanted to throw out there. So in this event-based annotation scheme, we have what we've called triggers, and these triggers consist of an event type, in this case, the label tobacco, and a span, in this case, the phrase tobacco use. And these triggers serve as a sort of anchor for us to collect information about a given event within the patient timeline. And this is used to disambiguate separate events within the patient timeline, or separate descriptions. These triggers connect to what we've called span-only arguments, and these arguments consist of an argument type, in this case history, and a span, in this case 7 years ago. And these arguments characterize the event, but the contents of the spans aren't easily mapped to a fixed set of classes, or not easily mapped to categorical variables. The second type of argument that we have in this approach is what we've called labeled arguments. And these labeled arguments are similar to the span-only arguments, except that they also include this subtype label, in this case, the categorical label, or the past, that essentially captures the meaning of the span. And so these the triggers can connect to one or more arguments depending on the complexity of the description of the SDOH. In this corpus, we annotated 5 different social determinants of health: alcohol, drug, and tobacco use, employment, and living status. And these event types are characterized through the trigger, labeled arguments, and span-only arguments. And I just want to highlight a couple of the labeled arguments that are featured most prominently in the balance of the talk. So all substance use events have a status time label that indicates whether the patient's substance use is none, current, or past. All of the employment events include a status label that indicates whether the patient is employed, unemployed, retired, on disability, a student, or a homemaker. And all of the living status events have a type living label that indicates whether the patient lives alone, with family, with others, or are homeless. So we're currently working to make this data set publicly available. It's already been released through a challenge. We're just trying to get through the last couple of steps with lawyers in order to get the data use agreements ironed out. But this data set hopefully will be made publicly available in the near term. If this interests you and you want to basically get on an email list, we have a Google group here that you can join that I'll make announcements through, as well as a GitHub page. Okay, so we used this SHAC data set in a national NLP clinical challenges, N2C2 challenge, that's focused on extracting SDOH. And in this challenge, we defined 3 different subtasks. Subtask A focused on what I would call general information extraction, or in-domain extraction. Task B was focused on generalizability, where the goal was to train on data from one institution and then apply it to another institution. And then subtask C focused on learning transfer, where participants were able to train on both mimic and UW data and then evaluate on UW data. And this subtask C is the configuration that's going to be relevant for the rest of the talk. So in this, as part of this challenge, we tried to develop a scoring routine that didn't necessarily exactly comply with a very traditional NLP task. And instead, we wanted to focus the evaluation on what we perceived as the clinical meaning of the extracted information. So we tried to define trigger equivalents, or we'd say two triggers are equivalent if they have any overlap and have the same type. So at the bottom here, we have this phrase cocaine that's labeled as drug, and this phrase cocaine use that's labeled as drug. Under our scoring, we would consider these to be equivalent. For the span-only arguments, we defined two arguments to be equivalent if they have the same argument type, in this case, the label type. They have the exact same spans, in this case, the phrase cocaine, and they're connected to triggers that are deemed equivalent. And then lastly, for the labeled arguments, we define this sort of span agnostic approach where we say that two labeled arguments, are equivalent if they have the same argument type, in this case, status time. They have the same subtype label, in this case, current, and they're linked to equivalent triggers. And we did not consider the actual span that was annotated because this subtype label, in this case, current, actually captures the important information that's associated with that span. In this N2C2 challenge, we had 15 teams that participated. All of the top teams used what are called pre-trained language models. And these pre-trained language models include large language models. The most common type of model that was used across the challenge, but especially for the top teams, was this BERT model, which was introduced by Google. And I just want to highlight two of the top performing systems because they I think are representative and they provide some context for some of our future experimentation. So the first is from the Microsoft Research and Nuance team. So Microsoft was the only team in the challenge that used a generative language model that takes in text and generates text. And they used this the T5 model, which was also introduced by Google, where the input is the target text, and then the output of the model is this sort of structured language representation of the event. So it resolves the trigger type, the status labels, and so forth. So Microsoft's approach is sort of text in and text out. And this is really quite popular now with experimentation with large language models. And this is a diagram from the Children's Hospital of Pennsylvania, or CHOP paper, where they have a multi-step approach that uses BERT. So the large language models, including the model that Microsoft used, is text in, text out, similar to when you interact with ChatGPT. But the predecessor to large language models that was quite popular is this model called BERT. And BERT maps text to some vector representation, and then those vectors can be used to perform classification. So in the CHOP approach, they have a given sentence, it feeds into BERT, it's mapped to a vector representation, and then they have separate classification layers that are identifying the triggers for the individual events. And then for each of the individual events, each of the identified triggers, they create a unique representation of a given sentence that feeds into BERT, which then maps it to a vector representation. And then they have a set of multitask, multi-label classifiers that then generate the argument predictions for a target trigger. So they accomplish this in 2 steps using this BERT model. So as part of our experimentation with SDOH, including SHAC, We also developed a BERT-based model. Large language models didn't exist when we were first doing this experimentation. And in our case, we started with this SPERT model introduced by Eberts, where SPERT stands for Span-Based Joint Entity and Relation Extraction with Transformer. And we augmented this architecture to add an additional classification layer so that we're able to extract all the information that's available in the SHAC annotation scheme. In this framework, a given sentence feeds into BERT. BERT maps it to each of the words or tokens to a vector representation. And then there are separate classification layers that identify the entities. In this case, this is identifying the phrases, the triggers and the argument phrases. There's the next classification layer resolves the subtype labels like current or past for the status labels. And then there's a last classification here, the relation layer, that identifies the relationship between the identified spans. So this table summarizes the performance of this MSPERT model consistent with subtask C of the N2C2 challenge. And then on the upper right-hand side, we have the top performing teams from the N2C2 challenge. And we can see that this model isn't necessarily state of the art. It's not beating the Microsoft model, but it's certainly competitive and suitable for establishing a baseline for model performance and performing an EHR case study. One of the things that I want to point out here is that in the EHR case study that Dr. Dobbins and I performed, then I'm going to talk about next, the phenomena or extractive phenomena that we used most heavily are the labeled arguments and the triggers. And these are also the extracted information for which we have the highest performance. So we're using the information for which we have the highest confidence in the subsequent EHR case study. Okay, so Dr. Dobbins and I explored the prevalence of SDOH in the University of Washington EHR. And so we collected all of the EHR data for a single year, 2021. We collected the data for all patients. We collected all structured records. We collected all the progress notes and ED notes, as well as these social history documents where this is this separate text field or text box within the UW EHR. And then we filtered the data set to restrict it to patients for which we have at least some social history text. And that gave us a pool of just over 200,000 patients and 400,000 text documents. The primary question we were trying to answer in this EHR case study is what proportion of SDOH are documented only in free text versus structured data. So we compiled all the data, we extracted the social history sections from these clinical notes, and then we applied our MSPERT SDOH extractor to all the social history text. And our goal was to try to perform an apples to apples comparison between the extracted information and the EHR, which ultimately isn't really, it's quite difficult actually to do or restrictive to do this apples to apples comparison. In the SHAC representation, we have this very rich and detailed representation of the SDOH, and we had to select a very small subset of the extracted information that we could directly compare with the structured data. So we're not using all of the extracted information, just a subset. And there were 3 areas where we found that we could have this direct comparison between our extracted representation of SDOH and the SDOH in the structured data. The first is the identification of any current positive substance use, the presence of any employment information, and any indication of homelessness. On the left-hand side is the distribution of patients for which we learned about their current alcohol, tobacco, or drug use. We had some employment information and an indication of homelessness. And then on the right-hand side, we have a bar chart that's showing where we learned about this, whether it's just in the structured data, just in the clinical next, or just through NLP, or through both. And we can see that we learned the most through the inclusion of the SDOH from the text about tobacco use and homelessness. So one of the things that, as I mentioned, that I think is really important to point out is that we only used a subset of the extracted information from the shack annotation scheme in this case study, mainly these label arguments as well as the substance type. But were many arguments or fields that we did not use. And as we were working with this corpus and this EHR case study, we wanted to be able to more fully utilize this information. So for example, thinking about tobacco use, we wanted to take the amount, duration, frequency, and history information and calculate some sort of tobacco severity score. Not that we would be able to compare that with EHR, but we wanted to figure out how to better use all of the extracted information. As we went through this and seeing both that it was quite difficult to use some of the extracted information, these span-only arguments that don't have normalized categorical variables, and seeing that we could really only do a sort of a limited comparison with the structured data, informed our future SDOH annotation. So in the normalization section of the talk, I'm going to present a different corpus that we created that's focused on pediatric patients. And you'll see that we try to alleviate some of the constraints of this annotation approach. Okay, so now I want to present our sort of initial experimentation with large language models on this shack annotation set. So we're continuing to use shack, this SDOH corpus based on Mimic and UW notes. And in this work, we continue to use the same evaluation criteria as the N2C2 challenge. And we introduced some additional, more lenient criteria where we would say that 2 triggers are equivalent if they're the closest triggers to each other. So it's quite it's a much more relaxed constraint. And then for the span-only arguments, we would say, instead of requiring there to be an exact match between the predicted phrase and the exact phrase, we say, if there's any overlap, we'll consider them equivalent. And this lenient criteria was intended to just understand what the model is doing well versus not. So the primary focus of this work was to try to understand how the performance of LLMs compared to our baseline BERT-based MSPERT model. And we explored different prompt-based strategies, what's called in-context learning, where the model is never explicitly trained on the task. It just uses its general understanding of language to reason about and perform the task. We experimented with incorporating information from the annotation guidelines, including examples of input-outputs. It's called few-shot learning. And ultimately, in our experimentation, we were trying to compare GPT-4 in an in-context learning setting, so GPT-4 without training it on the specific task, and comparing that with our MSPERT model that we had already fine-tuned on thousands of records to be able to perform this task. So on the upper left-hand side is an example annotation from the shack corpus. And on the right-hand side is a representation of one of our approaches that we call this BRAT standoff approach. So in this annotation example is created using a tool called BRAT, which stands for BRAT Rapid Annotation Tool. So somehow the name is also an acronym. I'm not sure how that works out, but in this annotation tool, it represents the annotation as a text document, similar to what's shown down here, where we have individual triggers or arguments that are identified, the associated labels, the character indices, the phrases, and subtype labels. And we found that when GPT-4 came out, it had some kind of, through some pre-training, for which we have no insight into, it already understood this BRAT format at least to some degree. And so we instructed GPT-4 to basically characterize the SDOH in this rat standoff format. We provided a summary of the annotation guidelines and one training example, and then the target text, and its task was to then generate this BRAT format. And then the second strategy, prompting strategy we use with GPT-4 is similar but not identical to the Microsoft approach in the N2C2 challenge, where they're using a generative model where we have some input text and the output is essentially a structured text representation of the identified labels. So here, similar to the standoff case, we provide a summary of the annotation guidelines, we have a training example, and the output is a version of the input text that has special characters and tokens that are inserted in order to identify the information that is found. So this table has both the top two teams from the N2C2 challenge, our MSPERT model, and then our GPT-4 results. And we can see that in terms of the overall F1 scores, that the GPT-4 performed quite poorly compared to these state-of-the-art models. And when we dug into this a bit, we did a detailed performance comparison between our MSPERT model and the two different GPT prompting approaches, the rat standoff approach and this inline markers approach. And we evaluated it using the N2C2 criteria. And we can see that our trained BERT model or SPERT model, MSPERT model, does much better than the GPT model, despite being many orders of magnitude smaller. And so one of the things that we tried is we tried applying these more lenient evaluation criteria, not because just to try to understand what was going on. And when in this these lenient evaluation, we're primarily relaxing the constraint that that the model needs to be finding these exact phrases in the text. And when we look at the change in the performance from the N2C2 evaluation to this lenient evaluation, there's a very small change in the performance of our MSPERT model that's trained on thousands of samples. And this kind of makes sense. But then when we look at the GPT results, we can see that there's a much larger improvement in performance, especially as it relates to finding the triggers and to resolving the labeled arguments. And so part of our learning from this is that it seems like, based on these results and our error analysis, that the GPT model is it's able to identify more conceptual information within the clinical notes. It's conceptual information related to SDOH, like what's the status of the patient's substance use, for example. But it was struggling to find these sort of exact phrases that met the specification in our annotation guidelines. So this is sort of combining with our learning from the EHR case study, where we used SHAC and we couldn't use all the information and we were only using the normalized information. And we are sort of tried to synthesize all of our learning from these previous papers and experimentation when we started on a new project related to pediatric SDOH. So here, the sort of general setup is the same as adult SDOH, in that we have this structured data and this narrative text, and we want to figure out how to use the narrative text. One of the key differences, though, is that for these pediatric patients, we're interested in their SDOH, but we're also interested in the SDOH of their caregivers. And from a sort of a motivation standpoint, the SDOH for the pediatric patients have a longer time to sort of impact their future health. And so it sort of maybe accentuates the importance of the pediatric SDOH. So in this corpus, we worked with clinicians to develop an annotation scheme to capture the SDOH both for the patients and for the pediatric patients and their caregivers. Um, and we made two big changes in the sort of in the general annotation approach. We're continuing to annotate these triggers, these phrases that are telling us that there's information about living or employment, because we need some way to be able to disambiguate um, different references. So here we have like the father's employment and the mother's employment. We need some way to be able to kind of separate out different descriptions. So we still have these triggers. But in this case, all of the arguments are what we previously called labeled arguments. Every argument has a value, or excuse me, a subtype label that's normalizing the contents. So there are no span-only arguments. And then all of the arguments just connect directly to the triggers. So from our previous experimentation, we found that we could very reliably find these sort of key phrases that are, cueing you into the fact that there's living information or employment information. And so we have this focus on normalization. So this table summarizes the SDOH that we annotated, spanning adoption, education access, employment, all the way through trauma. And for all of these arguments that we defined, there are a fixed set of classes that essentially create a normalized representation. So one of the things that is also important to point out is here we have, for some of these SDOH, we have an experiencer argument. So for example, is the mental health issue associated with the patient or their caregiver? So this table in the middle shows the distribution of the SDOH in our corpus. So there's a lot of information documenting living arrangement, but for example, very little that's documenting food insecurity. And this table on the right shows the inter-rater agreement, the agreement between the annotators that are using the agreement between the annotators in characterizing these phenomena. And in general, it seems like there's not necessarily a correlation between the prevalence of the SDOH and the degree to which the annotators agree. So in our information extraction experimentation, we're continuing to use this BERT-based pre-trained language model, MSPERT model, as a baseline for extraction. And we place more emphasis, or we have a more developed set of experimentation where we're trying to use large language models, generative LLMs, in order to extract the information. And we chose to use one model, this T5 model, that's an LLM that we could download, and it's open source. We could train it locally, and we continue to experiment with this GPT-4 model that lives on a cloud that, at least at the time, could not be trained on the data. So we were trying to understand what can we do with LLMs that we can train versus what can we do with LLMs that cannot be trained and can only learn through in-context learning, through the definitions that we provide in the prompt. And in this LLM experimentation, we included two different prompting strategies. One is this single step, what we called event strategy, that's very similar to the Microsoft sequence-to-sequence approach. And then we also tried a multi-step Q&A approach, which is quite common for these types of tasks. So this is showing an example for the event strategy. So here, the input to the model includes some basic instructions and an in-context example. We have the target text that we want to operate on that feeds into the LLM. And then what we get out of the LLM is this structured text representation that we can just write simple rules to kind of parse out in order to, and then recreate this event structure. So this is inspired by the Microsoft and Nuance approach. And then we tried this multi-step Q&A approach, where first we want to identify the triggers. So for each SDOH, we ask the model to generate a list of triggers. So these are only the living arrangement triggers. We also would ask another question about the employment or the food insecurity triggers. And then for each identified trigger, per the annotation guidelines, we know what the possible arguments are. And so then in a second step, we iterate over for each trigger, we pose a multiple choice question to resolve the label for each of the arguments. So in this case, we identified this phrase lives that's associated with living arrangement, and we're asking the model to predict the living status through a multiple choice questions. And we can combine the answers to both of these steps, again, to recreate this event-based schema. This table summarizes the performance. So here we have our trained MSPERT model. This is our BERT model or pre-trained language model. Here we have the T5 LLMs that are trained both for the event approach and the QA approach. And then we have the results that we achieved for the GPT-4 model, where it's not fine-tuned the task. It is only understanding the task from the prompting. And we can see that our T5 QA model achieves the best performance in identifying the arguments across all architectures, including our MSPERT baseline. And when we look at the GPT results, we have our GPT QA. We tried adding annotation guideline information, which resulted in a statistically significant improvement in performance. And then we tried incorporating a few example annotations through this few shot approach that further increased the performance. And our takeaway here is that the T5 model that's trained on this task still outperforms GPT-4 in resolving these detailed arguments. These are the things that we really care the most about. However, compared to the SHAC experimentation, the GPT-4 model is now at least competitive with these fine-tuned models. So some of our takeaways from this are that in the SHAC annotation scheme, we have these detailed trigger and span annotations, and only a subset of the arguments are normalized. So there's a lot of emphasis on finding specific phrases. And we found that using LLMs in this in-context learning approach where they're not trained on the specific data is that they perform much worse than models that are fine-tuned on these data. However, for this PEDSHAC data set, again, we emphasized normalization, and we tried to reduce the number of spans we're trying to find. The only spans we're trying to find are these trigger spans. All of the arguments are sort of directly connected to the trigger and have these normalized values. This is really moving towards much more like conceptual information than finding these detailed phrases. And in this setting, we find that LLMs in this in-context learning approach, again, where they're not trained on the specific task, are now much more competitive with these fine-tuned models. Okay, so far I've talked about creating annotation corpora, training and evaluating models, and some of those repercussions, the implications of different training strategies or prompting strategies. And for the last couple minutes of my talk, I want to switch gears a little bit and talk about our assessment of patient and clinician acceptability for automatically extracting SDOH. So the sort of the use case that we are exploring in this work is that we kind of envision that the one possible way you could use an SDOH extractor is you could apply it to the patient's longitudinal record, and you could essentially surface SDOH-related risk factors in the patient timeline and create a summary or sort of a distilled view of the patient's SDOH in order to identify social needs and pair them with relevant resources. And the focus of the work was then to try to investigate patient and clinician acceptability for this kind of AI-based extraction or summarization of the SDOH. So we conducted interviews with primary care patients and clinicians. We developed these storyboards. Each storyboard is focused on a different SDOH, where we sort of pitch this paradigm that a patient goes to the doctor at one point in time, they provide some information about their SDOH, then in a later visit, the AI system essentially uh, identifies or summarizes these previously disclosed SDOH and then brings them up to the patient. And we were trying to understand how acceptable this is. And we assessed the acceptability by individual SDOH on a 5-point scale, and we performed a content analysis of interview transcripts. This figure on the right shows the overall acceptability of using this AI-based extraction. And we found that both patients and providers found it moderately acceptable. There was the themes around the perceived benefits are that the participants could see how having a better understanding of social needs could inform care. They could envision how this potentially could streamline the review of prior notes, so potentially some efficiency gains. And there were also some comments about the potential to use this for billing or population health research. However, the participants raised concerns about the accuracy and the relevancy of the extracted information, and this ties in with, general concerns about data integrity. They thought that this has the potential to streamline the review of charts, but maybe also presents an additional administrative burden for clinicians and could be disruptive in the visit. And then all parties, a very prevalent theme was just concerns about privacy, transparency, and potential harm, especially if the model makes some sort of error. And sort of in the conclusions of this work, we tried to make some general recommendations. And these include trying to make sure that the extracted information is reliable and that it's drawing on the appropriate and comprehensive data sources, making sure that the presentation of the information that is extracted is flexible and accessible. And then throughout, if such a system was going to be developed and implemented, it would be quite important to be engaging patients and clinicians throughout the design and implementation to make sure that it's not just human-centered, but it's also like patient and clinician-centered. So in summary, we've talked about the presence of SDOH within the narrative text, the importance of this information, and how the text representations of SDOH complement the available structured information. In the extraction experimentation, we tried comparing using generative LLMs in an in-context learning setting versus training or training models in a supervised setting. And we found that it is possible to train LLMs to outperform prior models, but and it's not necessarily clear if that's due to architectural differences or if it's just that they're trained on more data. And we also tried comparing LLMs in context learning, and it was GPT-4 versus models that are fine-tuned. And across our experimentation, we found that the generative LLMs that are being used in context learning are much better at identifying conceptual information than finding specific phrases or spans of text. In this work, we explored different annotation approaches, where the most recent work uses the PEDSHAC approach, where we have an event structure where the information is mapped to these normalized representations. We find that this, trying to decrease the number of phrases that are identified and focusing on conceptual information is better suited for these LLMs and in-context learning setting. And then lastly, as it relates to ethical considerations, we see that implementing AI-based extraction within EHR systems could be is moderately acceptable, but that the implementation matters quite a lot, and that input from both patients and clinician is needed in the design and implementation. this work is spanning, this presentation spans many papers and is the result of the contributions of many researchers. We would like to acknowledge the various funding institutions. These are the papers that we discussed, and I'm happy to answer any questions.
This has been really, really wonderful. Thank you very much, Kevin. And I know I enjoy listening and learning. I know we've worked together for a long time, and I still I learn something though every time I hear you talk, and I hope our students and staff enjoyed this as well. I know I have a question, but I want to begin with folks who have kindly put their thoughts in the Q&A. I'll read first, and folks are also welcome to hop on and elaborate if they'd like to too. So Ariana first. Ariana asked, when you refer to term equivalency in N2C2, we love our acronyms.
Yep.
How are those equivalent terms determined? And she's not sure if this was previously mentioned as well. So Ariana, you're welcome to also hop on if you wanted to say anything else.
I'll take a shot at it, but
Okay.
please interrupt if you want to hop on. So here we would so for the trigger equivalence, where we are the check that we're doing is do they have the do they have the same label, in this case drug, and do the phrases or the spans have any overlap? In this case, they both overlap by the word cocaine, so we could consider those equivalent. But then for these span only arguments, we would say that like this type annotation and this type like if this was the true label and this was the prediction, we would consider them equivalent if they have the same label. In this case, they're both type. They both have the exact same phrase, cocaine, and they're both connected to the equivalent triggers. So here, term equivalent terms. Um, maybe so it's the so for the span only arguments, it's the you have to have like basically an exact match for the phrase. I don't know if that answers the question.
Got it. All right, thanks. And I think I'm just realizing that participants may not be able to hop on audio, so I apologize.
Okay.
But if as a workaround, you're welcome to use Q&A or chat, Ariana as well. The next is from GK. I think this is Dr. George Kim. And they ask, what are the measures of poverty that can be inferred, which is pedagogically one of the biggest factors impacting on child health and outcomes? So just say that one more time. What are the measures of poverty that can be inferred?
That's a great question. So um, I guess that I have to concede that I don't really know. So we worked with a medical doctor at Seattle's Children's Hospital to come up with this list of SDOH that we wanted to explore, but we weren't necessarily trying to define specific measures of poverty. So I guess I don't have a great answer. Sorry.
That might actually be, GK or George, feel free to please follow up or elaborate in chat or other mechanisms if you'd like. I feel like that might be a good segue to a question I had, though, Kevin. I think the traditionally in NLP we often we to solve, quote unquote solve or do as best we can, extract information or create some representation for a given task. The paradigm has been, right, we create an annotation schema, we train annotators, and we call that whatever the humans do the gold standard.
Mhm.
And then we kind of train or fine tune models based on that. And that's a lot of work, as we know,
Mhm.
right? And the moment we perhaps want to alter that schema, or we say, well, we're actually also looking for, for example, if imagine we didn't start with food insecurity, but we wanted to add that in. LLMs presents a somewhat different paradigm, it seems to me, right? Where it's we don't necessarily need that corpus up front. And when we compare, something that the Chat GPTs of the world can do versus our smaller fine-tuned models, uh,
Mhm.
at least at this point in time, the results as we saw here tend to not be quite as good, but they're often not terrible.
Mhm.
So I'm wondering your thoughts on, as an NLP expert, like when do we say, what an LLM can do is good enough, and kind of what's the right way to draw the line, and when people consult with you, how do you think about this?
Yeah, I think, yeah, it's a great question. I think that the landscape is definitely changing, and I think no matter so for this type of information extraction work, ultimately it's a classification task. You're assigning a label to something. And I think for these classification tasks, I think that we probably always need to carefully annotate at least the data that we're going to evaluate, because otherwise you can define a task and you say, okay, GPT-4 next year, GPT-5, extract this information. You don't have any idea how good it is, and you can't. It's unlike other tasks, like a text simplification task. If you wanted to simplify consumer health information, you could, start potentially by having an LLM do the task. You could inspect it, try to identify what you think is right or wrong. But for these classification tasks, I think that the starting point is still to curate, a careful description of what you want to extract. You have to label some data to learn so that you understand the task. That's part of it, is that the annotation is part of you as the researcher learning how this information is represented in your text documents. It ultimately refines your annotation scheme. And so I think that you need that as a baseline for evaluating LLM performance. I don't see a way to get around that. It would make me feel uncomfortable to turn an LLM loose without evaluating. But I do think you're right that the need for training data might be might be vanishing. And I think that, from the Shack results I presented, like you would say, oh, geez, definitely not. It definitely we still need to train the model. But I think that the low performance for GPT-4 and that on Shack was really about the definition of the information. So like we could have defined the SDOH in a different way, like maybe more similar to this PedShack paper, the pediatric SDOH, where then the model can do actually quite well. And so I have a student right now where we're trying to study the prevalence of HPV information, and we curated an evaluation set. We intentionally did not curate a training set, and we found that we get like quite good performance with a big LLM, and we're actually trying to like use that LLM as the annotator to train a small model, but we're still evaluating on some carefully curated data.
Got it. Well, that's really interesting. Those are really great points. I think we have time for one, possibly two. Oh, I see we just got one more question. We'll try to go fast, and if not, maybe if it's all right, folks can follow up with Kevin if Kevin's okay with that.
Great. Yep.
For this. So Shija asks, thank you for the informative presentation. Have you considered benchmarking the medical notes uh, to continue pre-trained generative for in-context few-shot inference? Might not be, let's see.
Yeah, my read of this is like, can you take the model, do continued pre-training, like the next word prediction task, and does that help? And is that your take, Nick?
That's kind of my
Yeah.
read as well. Yep.
Yeah. So I think it's a really good question. So one of the things that I've been thinking about as it relates to this task is in the sort of training cycle of an LLM, very first, this model is randomly initialized, then it's pre-trained on this next word prediction task. All it does is learn how to predict the next word. It's trained on billions or trillions of tokens. And then it is often then instruction tuned. It's trained on a diverse set of tasks to learn to understand and follow natural language instructions. And then maybe even there's some reinforcement learning with human feedback where humans are providing feedback and the model's refining. one of the things that's not clear to me is in this training pipeline, if you take this model that can follow natural language instructions, has been trained to do that, and then you go back to the initial training step of the next word prediction task, like how much of the instruction following might you lose if you go back and you do that? I think optimally you would you would insert this medical note pre-training early in the model's life cycle before you do these subsequent refinement steps. Another thing that's important to note, though, is I I guess I don't know this definitively, but my impression is that the current general domain LLMs, GPT-4, Meta's Llama, they're trained on so much text that just by virtue of having so much text, they actually are exposed to a fair amount of clinical notes. It might not be clinical notes for your institution, but they do seem to be able to reason about medical terminology, understand medical shorthand, things like that.
Right. I think we have time for one more question. I want to be mindful of time. Isabel asked, see, could you share your thoughts on current use of AI by health systems on one hand, compared to private tech companies in evaluating these social determinants?
So trying to separate out loud a health system versus a tech company. I mean, I do think that this is in you need the tech company to make the AI technology, and so like in as it's ported over into a health system, I think that it's the burden of proof is really on the company that develops the tech company, for example, to demonstrate that it has a certain level of performance or of goodness. I think that um, in our work, one of the things that we have seen is that you might not need like GPT-4 or whatever the next thing will come after it to be able to help you with social determinants of health. And so like, we showed that with a model that we could download and we could train on our specific task in a controlled environment that's run locally, that we can actually outperform these big models. And so like there's these big models that change and for which we have no insight. And so I think that there's this it can be useful to be thinking about what can the very biggest LLMs do, like GPT-4 is integrated in Epic and will email patients now, I guess. And that's useful. You probably need like quite a big model, that has very good reasoning to be able to do that. But if if your goal is to, for example, characterize like employment history, I don't think that you need to have this big, um, less understood system. You can have something that's smaller and very like task specific.
Right. And I think we got some very good examples of that in the talk today. So thank you everyone very much for coming, and we'll see you again next month.